for
Sorry, could you repeat that again, Dr.?
Of course. Yeah. I just wanted to say that I thank Dr. Joy Tsai for not only being my mentor, but also a pioneer in the osteoporosis world. And with that, we're open to any questions.
Awesome. And I'm just going to unmute you. Where are you?
There we go.
Okay, great. If you could put your questions back in the chat, everyone, I would like to be able to keep this going that way so that we can actually have this part recorded separately, which will work out really well. So let's see if I can see the chat on here. Okay, someone asked, what's your opinion on the EchoLight device as opposed to a Dexa scan?
Oh, and we also got another question as well. Dr. Tsai, have you used the EchoLight?
Oh, can I bring Dr. Tsai on as well?
Hi, I look terrible right now. I just
okay. All right, we won't do that.
So I'll be this faceless voice. But I did want to let you all know. I've heard of the EchoLight. I have to be honest. I don't have a lot of or any experience yet with it. It does sound exciting. My understanding is it utilizes ultrasound technology versus, say, traditional X-ray technology that you're used to with Dexa or bone density. I think it's exciting. So at this point in my mind, it's a research tool. I think it needs to be validated in order to make diagnosis and treatment decisions. So if you see trials as an opportunity to participate with it, certainly that makes a lot of sense to me. Given that it's ultrasound, it doesn't have the safety concerns with radiation, so that's great. But I think it stands to be seen in terms of how we'll utilize it in terms of the clinical applications. One thing I did want to say, I didn't want to scare you all about bone density and DEXA scans with the radiation. The exposure is quite low. It's extremely low, say, compared to a mammogram or a chest x-ray that you might get in the emergency room for any reason. So that's just one other thing to keep in mind.
That's great. Thank you. And, first of all, I want to say thank you so much, Dr. Dove, for your time tonight, and Dr. Tsai as well. I really appreciate all the efforts, both of you, especially Dr. Tsai. I've had a lot of contact with her, and I appreciate everything that you do, and you couldn't have a better mentor, Devanshi. I'm sure you agree. And I also want to say that everyone's asked me on private chat, we've had a lot of, I like all the content. Is there any way we could take a look at those slides, especially this time, because I'm not sure that will get recorded correctly. Unfortunately.
Yeah, absolutely. I'm happy to give the slides to you and you could distribute it.
Okay, and I'll try to match the recording with the slides. Unfortunately, I'm not sure how it will work because Zoom was on the blink tonight. But anyway, let's go ahead and take some of these questions. So someone asked you initially, what's the role of estrogen in healthy kidney function, specifically as it relates to renal calcium leak?
Yeah, so I know in general estrogen and hormone therapy was actually the first ever treatment for osteoporosis. But then there was a lot of studies that were done after that showed an increased rates in DVTs and PEs and increased risk of increased cardiovascular risk in general. So in general, it's not recommended. However, these estrogen modulators are now being used.
Okay, great. And then someone asked, what kind of vitamin K is recommended? And also, would you recommend taking a supplement of it, frankly?
I don't think you need to supplement your diet with vitamin K. Vitamin K is found in a lot of our diet anyway, lots of green leafy vegetables. So if you're eating that, that is plenty of vitamin K. And spinach also has a lot of vitamin K as well. I would say in states where there's impaired vitamin K metabolism, so if you're taking warfarin or Coumadin and you're constantly changing the way your vitamin K works, as that's the antagonist. In that case, then I would just have you or a family member, or anyone you know, just have an increased awareness and screening for osteoporosis.
Okay, because we do see a lot on the internet, and they talk a lot about different vitamins and supplementation, and it does get confusing just navigating that. So thank you. Okay. For a patient with very low lumbar T-score of -4, already taking anti-resorptive treatment for 2 years, could she switch to an anabolic treatment?
Yeah, I would defer this to Dr. Tsai if you have patients in your clinic that you do this the opposite way.
Dr. Tsai, are you there?
Oh, sure. Yeah, I'm still here. Yeah, I think these are pretty specific questions, so it kind of really depends on the full context of all of your care. I don't think that you have to, but you also, it probably doesn't hurt. So it's kind of a not helpful answer. I think it depends on what your results are on the anti-absorptive. Are you having fractures? What's the bone density response? Sometimes it can be disappointing in terms of seeing the repeat bone densities 1 year, 2 years after being on a bisphosphonate, since the changes are very small that we can pick up on the bone density scans. So it sort of depends on, clinically how happy your provider and you are with the results. I think the one scenario where it's clear where you probably would want to intervene is if your bone density is decreasing. I think then it's really a sign that for whatever reason, you'd be what we kind of in air quotes categorize as a non-responder to the medication, even if you're taking it perfectly faithfully. That would certainly be a sign to switch medications at that point.
If a patient comes to you, Dr. Tsai, with a T-score of -4, do you normally recommend an anti-resorptive, or do you recommend an anabolic?
That one is also subjective. I try to get holistically, the patients, the whole picture. If it's someone older or frailer, I might skip the anti-absorptive and go to something that's more potent in terms of knowing for sure they'll get it, like the IV bisphosphonate or the denosumab, which is the brand name Prolia. But if it's someone who's younger, say that they just happen to have the scan and they're 52 and they had it because they had a family history, I may or may not jump to the non-oral bisphosphonates. It really just depends.
Excellent. Okay. Someone asked, I have severe osteo in the spine, -3.8, and hip -3.1, and alendronate was recommended as the first line of therapy. I've been taking it for a year. I think this is somewhat the same question, actually. So,
yeah, I would probably say, to comment on that, it takes a long time to see any effect, and sometimes you don't see an increase in bone mineral density, but you just see stability, and that's good. Seeing stability, at least we're not seeing a decrease in the T-score. However, if you do see the decrease, then it would be pretty prudent to switch therapies.
Right.
But for now, I would recommend sticking to it.
Okay, that's excellent. All right. And let's see, is there any age limit on raloxifene, which is Avista? Is that Avista, the common name? Raloxifene? Okay. My doctor recommended, but I'm worried about the stroke risk.
I'll jump in. I wouldn't say that there's an age limit. It'd be more in terms of what you consider how high risk you are for stroke. So if you have other cardiovascular risk factors, such as high cholesterol, high blood pressure, certainly family history of stroke or heart disease, then you'd be a patient that we'd have more concern with the raloxifene, but I don't really go by age, as more just your medical profile.
And reading about this a little more, raloxifene, it was studied in trials among women from the age range of 31 to 92. So it's been used in that population.
Good to know. Okay. Once stable with meds, oh, good question. How can we keep the gains of that besides medication? Is weightlifting, or are there other suggestions that we can do besides, do we have to take medication for the rest of our lives?
I think that's a really good question. I think once you're stable and you've shown stability, then you may not have to take that medication for the rest of your life. And I think that other component comes into play where you're doing that weight bearing exercise. I think weightlifting can be helpful, but it's not as, as effective as if, for example, brisk walking or running.
Mm-hmm. Okay. All right. And then is horsetail recommended? I guess, is that an herb, horsetail? You don't really, yeah, I guess it must be. Does it interfere with thyroid, or do you know anything about that? And low T, this person has a low T3 and T4, but a skyrocketing TSH. Now, I don't know what that means. What is a TSH?
It's a thyroid stimulating.
Ah, okay. Okay. So would you like to address that?
Yeah, I think so. If on your labs, for example, if you're showing a low T4, which is thyroid hormone, with a high thyroid stimulating hormone, that's pretty consistent with hypothyroidism, and that in general has been shown to be associated with osteoporosis and an impairment in bone quality. So I think in general, hypo or hyperthyroidism is associated with osteoporosis. So if that is treated, that would help the bone health as well.
Okay.
Okay, thank you.
Yeah, that's great. Any thoughts on Maradyne low intensity vibration platforms? We have heard about those on this actual, those vibration platforms. Do you have an opinion on those? As a means of exercise that, are you familiar with that, either one of you?
I can jump in. I don't want to misspeak. If you had a full lecture on it already, you all could educate us on it. Because I can only share with you my general thoughts. I'm not familiar with that specific platform, Maradyne, but just in general, low intensity vibration. The idea of it, I think, is fascinating. Where if you can kind of get that stimulus to the bone cells through relatively passive stimulation, that would be fantastic. My impression through the kind of general collective research is exercise research in general is very hard to do. I don't think it's been as successful as we wish it were, but I think it might have a place in terms of clinical care, particularly for patients who can't move, say those who are hemiplegic or quadriplegic. I think that would be a really fascinating area. But if you keep in mind in terms of patients who are relatively healthy, walking, doing all their activities of daily life, those kinds of patients, when you look at the exercise studies, in order to see really significant or meaningful changes in their bone density, they're doing relatively high intensive exercise, like supervised weightlifting or kind of jumping or hopping exercises. So it does make sense that, exercise is probably good, but it's going to be a spectrum and it's probably going to match in terms of the intensity. So I don't think vibration will hurt, but in terms of how much is helping, I think it's very difficult to quantify.
Yeah, we've heard that too. From,
I'm glad I matched to your other speakers. It's always confusing when you have conflicting information.
We've heard the exact same thing from Sarah Meeks, that you probably are familiar with her, but she did discuss that. Okay, so this is an interesting question to me, because the trabecular bone score, there's actually a site you can go on and find a local reading for where you can get one done. And one of them is at the Center for Bone Density at Mass General. And I'm wondering what you think of the TBS scan, and do you use it, and what's your take on that?
Yeah, I'll just jump right in. Devanshi, let me know if you want to give your thoughts, share, certainly. So just to back up, TBS stands for something called Trabecular Bone Score. It's a little hard to describe without slides, but essentially what it is it is a software technology that was developed to be applied to the spine image of your bone density scan. So it's really nice in the sense that it's information or a scan that you're obtaining anyways as part of your routine screening or monitoring of your bone density. And what it does is it has this proprietary algorithm where it is mapping out essentially the pixels of that image and matching up if the neighboring pixels are either homogeneous or if they differ from each other, meaning, to put it roughly, do you have a lot of holes in your bone or in the trabecular bone of the spine, or is it more homogeneous and more solid, which would imply that the quality of the bone is better than you can imagine if you had a bone full of holes. Not to scare you all, I'm not saying your bones are full of holes, but this is just, a crude way of explaining what the technology is. I think the way that TBS or trabecular bone score is most helpful is applying it to something called the FRAX estimate. So Dr. Dove, as she had mentioned this in the diagnosis or when to decide when to treat for osteoporosis, you can Google this website called FRAX, F-R-A-X, and it gives you an estimate of your risk of fracture over the next 10 years. And if you look in the bottom right-hand corner, if you do have a TBS score, what you can do is you can insert what your TBS value is. It'll look like something like 1.2 or 1.3, something like that. And then you can adjust it. So there's something called a TBS adjusted FRAX score. And I would say that's where it's been best validated in terms of helpful of saying, okay, you have your FRAX score based on your hip bone density and your clinical risk factors. And now we also have this piece of information with the TBS, and it can either move up or move down your FRAX risk. So I think it gives it an even more accurate estimate of what your fracture is. The tough part with TBS, it's been out for a few years now, it comes down to practical issues, is insurance, getting it paid for, covered. You'd be surprised at, just adding a simple test to a report. And these days with electronic medical record, it requires a lot of a push through to get things changed. So I think you'll start to see some centers in the area. I know, I'm blanking on which one it is. I know there's at least one or two in the area that have it available. MGH, we do hope to have it available clinically, and we're just not there yet. Right
I
now,
thought you did.
Yeah, no,
Okay.
we only have it available for research right now. I think Brigham has it for an extra charge, I think, as they're working through the issues. I think there was news that it is, I think it's starting to be approved for pay by Medicare earlier this year, which is fantastic because Medicare tends to be the leader and a lot of the commercial insurance companies will follow suit. So I think it's something to keep an eye on. What I will say, as the value alone, I think it tends to be not as helpful. So if you see a number, you're like, oh, it's a great number or it's a really bad number. I really think it's best interpreted in the context of the FRAX score, not just as a number alone.
May I interrupt?
Sure.
I think I've heard that it's not very valuable if you have full-fledged osteoporosis, that it's more valuable if you're in the osteopenia range. Is that true or not?
I would agree with that, only just to back it up. So the tricky part or about the subtle part of this is, so I have fairly strong feelings. I think that TBS is most well validated, again, with use of FRAX. And then if you're familiar with FRAX is best used with those who have osteopenia. So indirectly, you and I are coming to the same conclusion, but mostly it's because, as you point out, if you already have been diagnosed with osteoporosis range bone density, you've kind of exceeded this threshold where we worry about the bone quality. So you don't really need quite the subtleties of other tools to help diagnose or determine when to treat for bone health.
Okay, that's great. Let's see. I wish there were more research, not by drug companies, I know it is very costly for a large study that's related to additional measures other than meds. Do you have an idea of percentage of studies regarding alternative measures? In other words, let's say, what is the question? I guess the question is, are there some alternative lifestyle choices that we can make that would make as big an impact as taking a medication? Is that a good way to put that? Or is that really what was asked? An idea of percentage of study? Yeah. Well, I guess that's, if anybody who wrote that would like to elaborate, if you don't mind being recorded.
My take on this question is, I think it is important to be discerning in terms of where your information is coming from. I think certainly the trials where the drugs were approved, they tend to call them phase 3 trials. For example, the one in Dr. Dove's talk, the Freedom trial, in terms of getting studying, evaluating denosumab or Prolia. Those just, practically they have to be sponsored by the manufacturer company. I don't think that discounts their results. I do want to be clear on that. But then they might have some more ancillary studies that come out, and then I do take those with a grain of salt in terms of how they're interpreted. So I think it just depends on what the topic is, and in terms of, being discerning in terms of how the report is interpreted. Because the information is just the facts. They have to present the facts. It's a peer-reviewed article, but you get to come to your own conclusions, whether or not you agree with the authors or not. In terms of alternative measures, I don't like to think of it as alternative in terms of black and white, like you either pick drug or no drug. There's a lot of great research where it's, people think of it as as alternative because it's exercise or supplements. It's just keeping an eye out in the bone health literature. Quantifying it, I don't know, percentage wise, if it's more drug related or non-drug. To me, that an actual number is probably not so important as just keeping an eye out for what's new and updated information.
Excellent. Thank you. Someone asked, do you ever recommend Prolia after a year on Evenity? If one opts for a bisphosphonate, how long would you stay on that before switching to another anti-resorptive? And I have heard this before too, that I've seen some doctors go to 2 anabolics in a row.
Mm-hmm.
And so what is your take on those types of things?
Yeah, I think that, with the Prolia, I think you'll start to see more information. I know you all are a very sophisticated audience, so this idea of sequential medications is increasingly important. Where, before we had limited options where it was just a bisphosphonate, you go on it for 5 to 10 years, and that's it. So now I think people are being more creative and being able to individualize these sequences. One thing to clarify when we're talking about the romosozumab and the Evenity earlier, right now it's only 1 year followed by another medication, because that's how it was studied, actually. So in terms of the approval studies, that's all the information that we have. So that's why it's always a 12-month course followed by something else. In terms of what's most well studied in terms of most number of participants in the research studies of the sequences, it's either Evenity followed by alendronate, the bisphosphonate, or Evenity followed by the Prolia. So I'd say both are probably very reasonable. In terms of the sequence of that Shelley mentioned of 2 anabolics, that one is probably more theoretical, I would say, in terms of what the providers are trying to do. They're really trying to maximize your gains. So I imagine that's probably in patients who have what would be categorized as severe osteoporosis. If your provider's choosing 2 anabolic medications in a row, there aren't a lot of studies, to my knowledge, that have formally studied that, but theoretically it does make some sense to do.
Okay.
Can I just, I'm sorry to interrupt, but I was the one who had the non-articulate question about research. So I just want to clarify it. I guess the bottom line is I know research is extremely expensive, and doing a good study is very, very expensive. And so I guess there's a little frustration on my part that there isn't enough known about, maybe the word alternative is not appropriate, in addition to, or more things that we can be doing that we could know about in terms of supplements, in terms of eating different ways, in terms of, it just seems like nothing is really substantiated for those things except for calcium and vitamin D. And of course, they're finding out more about vitamin D these days. So it's difficult, I think, for me anyway, as a person who also wants to know more about other things I can do that are not supposedly going to help, but that I feel a little more confident in helping me. And maybe in addition to medication as well. And I know that some of the studies are really difficult when I look at research because there's so many variables. Like when you look at a research that says 10% you may have this symptom or whatever, but the thing is, who are those 10%? So you never really know for sure, but so that was my thing, is that I wish that more places could fund other things other than the medications.
Yeah.
So do you know that there's more?
I hear you. I'm not disagreeing,
Right.
in terms of research funding, traditionally, I think a lot of researchers, they do ask for federal funding through the NIH. A lot of the osteoporosis work is done through the agency called NIAMS, National Institute of Arthritis, Musculoskeletal, and blinking on the last one, I apologize. But that would be the main kind of agency. There is an alternative one. I'm also blinking on its full name too. It's a complementary and alternative medicine. So I think probably looking in terms of projects that they have funded could be helpful. But as you point out, it's a practical issue. It's slow work. It's expensive work.
Right.
People who are motivated to pay for it are either the companies that profit from it, right?
Exactly.
And they may or may not be interested in running those studies. What I will say, though, is that I also think that there might be a bias. Maybe people are less interested in it because it's so difficult to do, and that the improvement that you see is fairly incremental. So it's very hard to pick up those subtle changes. And, if you're working at this research project for the next 5 years at your life, you kind of want to be able to show something that was helpful to your patients. I think that's also another reason why it doesn't tend to be so prominent in terms of the research studies that you see. But you see them here and there. Some fun ones that come to my mind is I remember seeing one where they had people eat mushrooms every day for I think 6 months, and I think that improved their vitamin K levels or something like that, and they did see some improvement. So you see little projects here and there like that. So I think it's just keeping an eye out. Don't quote me on that one, but I just remember
I won't.
eating mushrooms for 6 months, and that was a positive thing. And I thought, you might get tired of mushrooms after 6 months. But there's work like that for sure out there.
That's great. Thank you. Those are great questions. What is the difference, someone asked, between estrogen and bisphosphonates on their effects of bone resorption? I know you spoke about that earlier, Devanshi.
Yeah, I could talk about that. So the way bisphosphonates work is that it's a pyrophosphate that integrates into the bone matrix and causes osteoclast apoptosis. So it actually kills the osteoclast and prevents its production. So that's different in the way that estrogen works, is that estrogen kind of relates with actually the signaling pathway in between the way osteoblasts and osteoclasts interact. So it inhibits the release of rank L, which is expressed on osteoblasts, and that inhibits the further maturations of osteoclast cells.
Mm-hmm. So how would you know whether one would be a better choice for you?
Yeah, I think based on, it kind of goes back to what has been shown in terms of first line therapy. I think in general, I know this kind of answers the next question as well about the prescription of compounded hormone therapy of estrogen and progesterone. So that's no longer recommended as first line therapy, that it's really these bisphosphonate medications. And again, in addition to medications, I think a strong emphasis is on these exercises that I mentioned here, as well as dietary calcium, vitamin D, and then basic and stable vitamin K metabolism.
Mhm. Okay, well, thank you. That's helpful. Someone also wrote that I heard that calcium supplements will increase heart disease and breast cancer. I don't think you're talking about a lot of supplement. I think you said 1,200 milligrams a day. So I guess that's what you should, I mean, that's what we're probably talking about, but what's your take on that?
Yeah, I think at doses of 1,200 a day, I see a lot of patients with hypercalcemia, and in general, you don't really see these long-term effects on cardiac disease and long-term once it's down, but 1,200 milligrams a day is the recommended intake, and that won't cause an increase of breast cancer or cardiovascular disease. And that kind of leads to the reason why estrogen progesterone therapy is no longer recommended as first line is that in kind of the Women's Health Initiative trials, they saw that it did reduce fractures, but it did increase the rates of breast cancer. It did increase the rates of cardiovascular disease and thromboembolisms as well.
Okay, very interesting. Do you have any info on anastrozole, which is an aromatase inhibitor for breast cancer, I think? Or breast calcium. No, it must be breast. I don't know what the CA means, but anyway, effect on bone, especially if one is already more than 5 years post-menopause. Oh, okay. Yeah. In other words, is that going to affect your potential for breast cancer if one is over the age of 70? Well, that's the second question. Okay, so let's deal with the first part of that. I've never heard of that drug, so I don't know that's not a osteoporosis medication, is it?
Yeah, I can just jump in. So the anastrozole is the medication that would be a treatment for breast cancer.
Okay.
This person asking, and it's an appropriate question in the sense that we know that anastrozole can have negative effects on bone health.
Okay.
So I think in this situation, it would be a matter of doing the same routine screening in terms of risk stratifying, how high or low, what's your starting bone density. So that can help your oncologist determine how long you want to be on the medication for, and then also if they want to refer to an endocrinologist to start any treatment for bone health at the same time too. So it's really about balancing the risks and benefits of everything together.
Oh, that's helpful. Thank you. And I hope that was helpful for Justine too. The second half of that is if one is over the age of 70, is it necessary to take an osteomed given the hip FX risk?
This one, I'll just take a stab at it in the sense of, I'm really not seeing the well, a lot of you seem to be focusing on the age. I'm really just focusing on, what's your lifestyle? I don't really care what your age is. You can have very frail 65-year-olds or very active 85-year-olds. So, it's not really by the number. I think, I joke about it. It is true that statistically speaking, older patients tend to be frailer and they do have higher rates of fracture. So, you keep that in mind. For example, that FRAX calculator I keep mentioning of the 10-year risk factor, it does factor in age. That's one of the pieces of information that you plug in. So age is something to keep in mind, but it's not black and white in terms of saying, okay, once you cross this age, then boom, you have to start a medication. I don't think of it as that.
Well, this is very good to see that Devanshi talked about the types of exercise she recommends. Do you want to elaborate on those for a minute?
Oh, sorry. So yes, definitely. I think so. In general, exercises can be divided into high intensity versus low intensity. And these are the high impact versus low impact. So these are the examples of high impact exercises. So we're really, whether it's dancing, soccer, hiking, stair climbing, tennis, all of these really help and have been shown to be helpful in osteoporosis and are in the high impact group. In people who have, for example, evidence of fractures or severe osteoporosis, brisk walking is also fine.
Okay, good to hear. And then The question below it is, do you recommend those high impact activities for a minus 2.5 score on your spine, or even a minus 3.2?
I think in general, so brisk walking is shown to be safe in fractures. So I would apply that the same for someone with a negative 2.5 as well.
Mm-hmm. Okay. All right. Let's see. Are there particular calcium supplements that you recommend? Do you think the type or brand matter?
I don't think the type or brand matters, but as long as it's something that does not look fake or like a sham too, I think that's fine. I think ultimately calcium is calcium, and you're probably getting enough in your diet actually, and the rest is just a supplement.
Okay. And I think I see one last question here, and we have definitely worked both of you quite a bit tonight. So thank you. Referring to the Women's Health Study, can you comment on the difference between progestin versus progesterone use, which are compounded hormone use, progesterone? Not, you know, what is your take on the difference? Do you have an opinion on that?
You know, honestly, I have to go back and look at the original studies. I don't want to misspeak in terms of the differences between those. I usually think of it as not the different types of progesterone or progesterone, but as of making sure that you have the progesterone plus estrogen when you're discerning the literature of, are you looking at something that was estrogen alone or estrogen plus progesterone? So I don't tend to differentiate between those types of progesterone specifically always for bone health. And then in terms of the compounded ones too, you just want to be careful that you're obtaining it from a reputable pharmacy so that the percentage of what you're getting is truly what you think that you're getting.
Yeah, absolutely. Do we have time for one more? Just a quick one, actually, if you can answer it quickly, because we're going to end it up ending again. How long does the average person stay on alendronate before switching to another med?
I think it depends on what we're seeing in the Dexa scans, but typically what I've seen is that you give, 5 years a chance. That's enough to show stability or improvement in your bone health, and it just takes that much time too.
That's great. Well, I have to tell you that this has been phenomenal, and I really appreciate your time, both of you. To have both of you on, what a treat. And Devanshi, you've done so much to educate us tonight. I loved your slides. I can't wait to pour over them again, because I don't know about everybody else on this, but I need to see it again and again to have it totally connect with me. So thank you so much for your time, for your energy, for all the effort you put into the talk. And it was great. Thank you.
Pleasure. Thanks so much, everyone.
And thank you, Dr. Tsai, as well. What a great night.
Thank you so much. Appreciate it.
Yes.
Thank you.
Thank you. And everyone, why don't you just call back in and we'll talk for another 40 minutes. And thank you, Devanshi.
Okay.
Our best to you. Okay, so let me see here. Let me just say, there we go. I think we could preempt the fact that this is going to end and call back. I do want to tell you a few things, so I'd really appreciate it if you would call back, even if we don't, however long we do speak. I have some important announcements to make, so thanks for all the great questions. I hope I got to all of them. It was hard. Sometimes my message was jumping, so anyway, thank you for staying on. And why don't we just call back in, because I know we're going to be.
Shelley, it's the same link that we used, the same link again?
Same
Okay.
link again, one more time.
Shelley,
All right.
Yes.
before you close, can we download the chat?
Oh, I did download the last one, so I will do
See
that.
how to do it tonight. For some reason, I don't see a thing to download.
No, I'm gonna do it. I'll do it. It might take me a minute.
It's right there at the bottom on the 3 dots. It'll say save transcript, save chat. Just go ahead and click the 3 dots and click save chat.